Patient named Bindu, 49-year-old female patient hailing from Uttapalam, Palakkad. She's a bank employee and currently she's under implant therapy.
She's a bank employee. Currently she's under implant therapy.
Person is already undergoing implant therapy and you have completed the upper arch. So how many implants have you placed in the upper? 5 of them. They are in 1, 6, 1, 4, 1, 3, 2, 2, 2, 3 positions. And what about the sizes of implants? Diameter is quite okay, 4.25, but length is 6.5. Then 1 in 1, 4 region, that is 3.3 diameter into 11.5 long. Then you have got one in canine, very crucial one that you have placed it as 3.75 to 13. That's also quite a good implant. Then you don't have anything in the anterior. Does this patient has any tongue thrusting habit also? Patient has. So canines becomes very crucial in tongue thrusting. And moreover, you need to place another additional one between the canines if it's possible, since you have to withstand the tongue thrusting habit. Tongue thrusting, whether it is on periodontium or on implants, it is definitely a challenge to the prosthesis. But you have placed one in 1, 2, 2 region. That's 3.3 into 11.5. It's an impressive size. Then you have got 1 in 2, 3. That is 3.3 into 13. Yeah. So are you planning to place anything distal to that second quadrant region? You need to place something more. At least one more to accommodate something till second premolar or first molar. That's needed. Now we are starting off with the lowers. Okay. Can we see the clinical picture of that lower area? Every evidence of tongue thrusting habit. Uppers, I think this picture was taken before the implant placement. Now there is no more teeth on the upper arch. Lower has got third quadrant as canine, 2 premolars, and is that first molar or second molar? First molar. First molar. But all seems to be periodontally weak. Okay, what about the X-ray? Almost all teeth have lost periodontium till the apex. Though it appears to be an immediate implant site, hardly any bone structure remains around the tooth. So it's all something very similar to conventional if you're planning also. But you should be trying immediate implants here. Because immediate implants give this maximum bone width at that point of extraction. Because every next day after extraction, you're going to have a collapse of the socket area. So the ridge diameter the width of the ridge will definitely reduce. So anything possible at that point of extraction should be done. That's what this immediate implant is all about. So you got 4 teeth over there and one edentulous area to 7. Since you are not planning much of a molar up to 7 on second quadrant, there is no point in giving an additional implant to the region of 7. Your possible extension of the lower FPD will be till 6, right? So restrict it to 6. If you have an additional implant to be placed, let it be placed somewhere anteriorly, not to the posterior. Right? If you have one implant, which you have got an option of placing in the anterior or somewhere in the middle area or to the posterior most region is not going to be of any use for the patient to bite, because that person is not going to have anything beyond the level of first molar in the upper arch. So there is no point in giving an additional implant lower to it if you have got only a choice of 5 or 6. Include it within the denture region that is going to occlude with the opposite. So that means your last implant on lower ridge is going to be in the position of 1-6, not in 3-6, not into 3-7 region. So 3-6, okay. So where else? After 3-6, then we have 3-5 there. But the problem with 5 is, yeah, apical to the lower 5 comes the mental foramen. It's not that you cannot place an implant over there, but length matters. Cannot go to that level of mental foramen. So 4 or 3. That's 3 only, right? What you have there is 3. Is it 3 or lateral incisor? 3 only. Proclaimed, angulated. Okay. So that means you need to place one in 4 and the other one in 3 itself. Okay. Okay. So you can place one of those implants today, not all the 3 together, or not 2 together. You go in for molar. Okay. So you can plan up with the implant in lower third quadrant, first molar region. One implant in that area. Luckily, you have got a bifurcation on that tooth. So that means you have 2 sockets. If by any chance, if that roots were fused together, then you wouldn't be having an immediate implant possible site there, because it becomes too big for any immediate implant placement. So primary stability becomes an issue. Then what we can derive is the support from the apical area, apical to the root tip, if it is a fused one. But then again, the whole of the upper area, the middle third and the the platform third of implant will be in air. There you have to graft it. Too much of grafting is going to happen in that region. And it's not a very reliable thing to do. So if it was a fused root, then you would have tried what else? Socket preservation and implant later. So that's going to take another 6 months time for placement, another 3 more months time for it to heal and osseointegrate. So the entire process is going to become another 8 to 10 months procedure. So immediate implant shortens that loading period of implant also. At the time of extraction, if you place an implant, then 3 to 6 months you can go in for the loading. So that shortens the treatment period. So here you have got 2 roots, the distal and the mesial one. Have you done any other investigation? Some imaging? So you have planned it on an IFPA. Okay. So that's the root over there. You can see the mental foramen apical to the premolar. It's very clear there. So from the bone crest to the nearby anatomical landmark. Nearby anatomical landmark for that area becomes nearby root or inferior alveolar canal. Apical is inferior alveolar canal. How far is it from the crest to the inferior alveolar canal? 12.76. So make it 12. So you got a available bone height of 12 mm from the crest to the, is it to the inferior alveolar canal border or 2 millimeters short of it? So 12 mm is 2 millimeters short of the inferior alveolar canal. So that means you can utilize all the whole 12 mm there. If it was distal root is still it's exhibiting more of bone loss there. But once you extract that tooth, then if you place an implant on the mesial root up to the level of crest, then there are chances that the distal screw, the area distal to that implant on near to the platform, these threads of that implant distal to the crustal region is going to get exposed because that area is a socket. So you need to place it in the area of that distal root bone rather than the mesial bone crust of the mesial root of a molar. Take the reference of distal root and place the implant. Though we are planning it on the mesial root, plan it according to the bone position of the distal root rather than mesial root, because if you place it corresponding to the mesial bone crust area, you will have a spread exposure on the distal aspect of the implant there, since you're planning for an extraction of both the roots. So the thread on the distal aspect of that implant is going to be exposed. So better take the reference from the distal root crustal bone region and place it. Whatever is there extra on the mesial region, let it be there, so that it will help in the integration time. Later, when you retrieve the implant, if you want to shape it up, you do it at that time. Understood? So you have already planned it as how many millimeters? From the bone crust to the inferior canal, 2 millimeters short of it. How many millimeters of length? 12 you have planned it. But now you need to shorten it to the level of that bone. So that will make it less than 12. So it will come to probably to 10 alone. 10 millimeter, if you place an implant in that particular mesial root region, subcrustally to the level of distal mandibular crustal bone region, distal root of a smaller region, then finally you're going to get at least 1.5 millimeter subcrustally from the crust, still 2 millimeters short of the inferior canal. That's how you're going to get it. But since this being a mesial root, usually the lower molars have got 2 roots in the mesial region and 1 in the distal region. That's the normal anatomy. Whatever it is, it's going to have a flat root. A flat root. That means buccolingually, the width will be more than mesiodistal. So when you place an implant in that region, it is possible that you will get a jumping space in the buccally or lingually of aspects of the implant. So grafting is probably a need. You need to graft that area. And what about the socket on top? Will it get closed by itself? You need to support it. And your implant is going to be 10 millimeter alone. You cannot afford to lose that bone implant contact any further. Right? So you want to plan something to get the socket mouth closure as well? You can try for some connective tissue graft in the socket so that the implant will be stable in the mesial root and there will be an opening on top that need to be covered with a connective tissue. You can go in for some kind of minimally invasive connective tissue graft from palate. So you don't need to make a big window there. Do you have any edentulous space on top? Just show. Can you zoom it? Still. So you've got a 2, 4, 2, 5, 2, 6 region with an edentulous ridge. Edentulous ridge is also keratinized mucosa. As long as it is having much of palate over there. If it is lower one, then you need to be very careful about the edentulous area as well, because you might not get enough of edentulous ridge for collecting a connective tissue graft. Whereas when it comes to palate, you've got abundant attached mucosa and keratinized mucosa there. So you can take some small graft from there, exactly corresponding to the size of your socket mouth, and place it there and suture it. So which would be an ideal area here to procure a connective tissue graft? The condition is you need not go to the medial aspect of the palate. You can restrict within that ridge region or maybe slightly palatal, which would be an ideal area. That's in the socket area, right? Why should you go into the socket region? Why not slightly distally? Yeah, somewhere there from the ridge. Yeah, that side. It was an interdental papilla there between 7 and 8. Yeah, from that region, you can take a punch incision or a small window-like opening there. Take a graft from there because you don't expect to get any anatomical crucial structure over there. As you go medially, you'll end up in greater palatine vessels. Here, you don't expect anything in that region. It's going to be a plain ridge. So open a small window there. Yeah, somewhere there. According to the size you need, a small window. Take whatever connective tissue you want of your size. Again, that could again be a split thickness one. You need not involve the periosteum. So a window from there, then again another split thickness graft from there, which is free graft. Place it in the socket mouth and suture it. That is possible. Am I right? Yeah. So what about the diameter of the lower? 10 is fixed to be the length. What about the diameter? So 4.71 is the mesiodistal width of the root. Of course, the anterior-posterior will be still bigger. If you place a 4.71 platform size implant there, you will get an engagement from both the sides, probably both the sides. But as you're planning to place it 2 millimeters subcrustally, 1.5 millimeters subcrustally, I think you've taken another one value from there. What is that? 3.73. So if you place a 3.75 implant there, you will get engagement from both the sides. Whereas if it was still on crustal area, it should have been more. So 3.75 in that region should be fine to get in. And a primary stability enough for the implant to be placed there. What about still further down to it, apically? So it's a root form shape of the root itself, conical, narrower towards the base. You have got 2.51 only in the apical region. So 3.75 should be sufficient enough for that particular region. If you still want to go in for a wider diameter, 4.25, right? So 4.25 also will give all sort of primary stability for this root as well. I think you should be trying for larger diameter. Larger diameter because it's the distalmost implant in that FPD and the length is not much. It's only 10 millimeters. So going in for a wider diameter would help you. Okay. So let's fix it as 4.25. Since you have got 3.75 and 4.25 in that range, you don't have a 4 millimeter range for your implant kit. So we'll fix it to 4.25 into 10 with reference from the distal socket, distal root socket, not the mesial one. So it will be naturally subcrustal. So all care should be given to avoid the inferior canal there. Since you have already planned it up with 2 millimeters short of it, you shouldn't be having any problem as such, but always make every possible scrutiny in between to make sure that you are not reaching the canal. So how will you go about it? Extract it? Okay. Then what kind of an incision will you place here? You need to place any incision to see the bone. You want to see the distal bone, right? So if there is an interradicular papilla there is any connection between the two roots by soft tissue, that we need to sever it. And we don't need to open a very big flap. You can just visualize the entire surrounding of that socket bone. That should be fine. If at all any soft tissue is hindering your vision to that area, then you can probably open up that particular region, see the entire crustal bone. You have to visualize the entire crustal bone and the bone on the distal root as well. So those bone crust should be exposed, because according to that you're going to place the implant. That's going to be your reference, right? Okay, so extraction, expose the crustal bone, then lance drill on the mesial root. How deep will it go? How much is that bone, socket bone height? The height of the bone surrounding the root. So out of 12, we have got how much in the apical region? 6. That means it's 6 millimeters. 6 millimeter of bone is covering the root. 6 millimeter apical to that is a possible thing. That made 12, right? Now you have cut short it to 10. So that means, anyway, if you see a visual obstacle from the top, from the crustal bone, lance drill can go 12 millimeters. But already the lance drill will go 6 millimeter into the socket. There only it starts its drilling. And another 6 millimeters is permitted. So how much is your blade? The lance blade, 8 mm. So 3 or 4 millimeter into the socket. That should be your criteria. Because 8 millimeter means 6 millimeter is going to be in the socket. If you push another 2 millimeter, your blade will disappear. Another 2 or 3 millimeters just to confirm the angulation and position of it. Take an X-ray. Thereafter, pilot, can you use your stopper here? It's an immediate implant, right? The stopper will go into the socket. So the stopper is not going to be helpful here. So you have to be very careful about your drill length itself. So the next drill will be pilot. How deep it should go? Hmm? 12 mm from where? From the crustal region around 12 millimeter. Okay, so that need to be calculated and kept initially. The entire length is 12 millimeters. So are we going to take the reference from the distal area or the mesial root, mesial bone area? From the distal area. So from that region, how much should be the depth? Roughly about 10. We'll have to confirm it with another IOPA. You need to plan it from the distal root as well. So if it says 10 millimeter, then 10 millimeters. 10 millimeter should be the depth from the distal root level, distal crustal bone level. If you're taking the reference as mesial bone crust, then it will be somewhere around 12 millimeters. Okay, pile it over then. 2.8 is same depth. 12 millimeter from the mesial side or 12 millimeter from the distal crust, the mesial crust or the mesial crust, it should be 10 millimeters. Then 3, okay, then 3.5, then since you're planning for 4.25 and it's an immediate implant, then stopping it at least 2 millimeter short of your, not 2 millimeter, 2 drills short. That will be helpful in implant placement. So since you're planning for 4.25, you got a 3.75 drill to follow. You're stopping it in 3.5. So 2 size short of the final implant will help you. Okay? Okay. Then you're going to get a connective tissue from there. Once connective tissue is ready, you will place the implant. Okay. If it requires some kind of a grafting, do it. Then place the connective tissue and suture it so that you will get a good coverage of the socket region as well. Right? Yeah, any doubts? Okay, we'll go ahead.